Hello, everyone. Good to see so many familiar faces, just names under the pictures, so with no pictures at all. I recognize many names here. I'm a psychiatrist with Beebe Healthcare now, headquartered at Lewes, Delaware, with two hospital centers and extensive network of walk-in clinics, primary care and specialty care offices throughout the county. And it has been about 4 years since I left my position as the medical director at the Root Center. And I'm so happy to see that many of you are still there. You were able to take part in an amazing transition, I think, from Hartford Dispensary, several clinics with single task of dispensing methadone to expansive clinical system with multitude of locations, with different levels of care, services in a very short period of time. And now known as Root Center for Advanced Recovery, and I'm very proud that I was a little part of it also for a while. So I live in the coastal town of Lewes and practice psychiatry here as well in Sussex County of the first state. And I was asked to put together a psychiatry service line for Beebe Healthcare, which is serving community of the Sussex County. So, and we accomplished that in just over 2 years, from not having any services at all to a thriving business with 5 psychiatrists, therapists. We provide treatment to thousands of patients here now. So when Stephen reached out to me and offered to take part in this lecture series, I didn't know what would be an interesting topic for you to hear about. And I chose to talk today about alcohol use disorders in older adults. And it wasn't a wise choice, it turns out, as the issue is so vast, that it will be very hard to touch on all the aspects of the problem and not to get lost. I'll do my best, and you will try to do your best to cope with my accent for next about an hour, hour and a half. So, first of all, disclosures. So I don't have any disclosures. I'm not getting paid for anything by anyone. And the only thing I have to disclose that no part of this presentation was assisted by or created by ChatGPT. And it should be pretty obvious given how busy my slides are and the times I will be moving from topic to topic without any smooth transition. And by the way, when people express concerns about artificial intelligence intrusion into mental health services, I will tell you that I'm not worried about it. And the reason I'm not worried about it is because we don't have a single patient who is like another one. Each individual is very different. And I don't think there is an artificial intelligence which is going to be able to engage every individual patient while taking into account their background, history, preferences, etc. So the questions we would like to answer today, some of them at least to some degree, is this really an issue for all the adults? Who is at risk? How to talk maybe to older adults about alcohol use? Is it difficult to diagnose alcohol use disorder in older adults? And what is the best treatment strategy? So alcohol use disorders in older represent a significant challenge for clinicians. It's widely underreported, difficult to diagnose, difficult to treat. So this presentation, I will try to focus specifically on practical issues for clinicians who encounter older adults with suspected alcohol use disorders. As you know, alcohol is the most commonly used substance by older, and there are more adults who are misusing alcohol when it was years ago. There is some statistical numbers here, but that's not important for each individual patient. The signs and effects of alcohol misuse, including binge drinking, different from between older and younger adults, and we'll talk more about it. And you will encounter a lot of those patients in your clinical practice. We can't go without a cartoon. I can't find anything wrong with you. It must be the drink. And the patient says, okay, come back when you're sober. So first of all, I'd like to focus on DSM-5 criteria for alcohol use disorder. And I went crazy here with colors a little bit, but I wanted just to separate different items here. So DSM-5 defines alcohol use disorder as a problematic pattern of alcohol use leading to a clinically significant impairment or distress as manifested at least 2 of the following occurring within a 12-month period, right? And when it follows with 11 different items. And item number 1 and number 3, they are related to amount, time spent, and frequency of use. So alcohol is used in larger amounts, longer period of time than it was intended, and a great deal of time is spent on activities necessary to obtain alcohol. The items under number 2 and number 4 are more about subjective struggle with addiction and gain control. So it's a persistent desire and unsuccessful efforts to cut down and cravings. When items from 5 through 8 have to do specifically with social functioning issues, right? It's failure to fulfill major role obligations, continued drinking despite having problems, giving up activities of social, occupational, recreational nature because of alcohol use, and continued use despite it is physically hazardous. And finally, items from 9 through 11 have to do specifically with physical and physiological impact, and primarily tolerance, withdrawal, and different physical and psychological problems as well. As you could see, the requirement that there are only 2 criteria necessary to be met to make the case for alcohol use disorder. For older adults, sometimes identifying even 2 criteria may be challenging, especially if the whole source of information is the patient himself or herself. It's true for anyone, but especially true for older adults, that when making a diagnosis, we would obtain collateral information from their family members or friends. And in my office, it's not uncommon to have a patient and their spouse engaging in very lively discussion, about discrepancy between what's perceived by patient and what's actually observed by the family in terms of what's going on. So let's take some time and go over each point of diagnostic criteria in more detail, as I believe if we apply the same assessment template to older adults as we do for younger people, we are at risk of not identifying problem. In other words, DSM in this case makes us clinically blind. Naturally, aside from recruiting subjects for research study, why would we need to establish diagnosis using DSM-5 criteria? Well, billing, of course, other issues, but primarily because we need to propose a treatment plan to a patient, right? What if I tell you that in older adults, while evaluating for alcohol use disorder, we need to intervene sometimes, even when patients don't meet the criteria. And later, you'll be able to see it for yourself. I'll skip a couple of slides here. But so the first The first criteria, alcohol is often taken in larger amounts or over longer period of time. So quantity frequency measures may be less effective when assessment of impact on overall well-being and quality of life in identifying substance use disorders in this population, because older adults may need less of a substance to feel its physical effect. So this criteria may not really be sufficient. And some people may have difficulty keeping track of amount and frequency of substance use, and sometimes their age-related or medical problems or cognitive problems may decrease that ability. So especially if we rely on self-report by a patient. There is a persistent desire on a successful efforts to cut down or control alcohol use. I'll tell you from my experience, there is no desire or effort to cut down in most of the cases of patients I see. And most older adults don't even know that their drinking is problematic. And number three, a great deal of time is spent in activities necessary to obtain alcohol. Well, again, for older people, they need substantially smaller amount of alcohol compared to general population, and therefore we don't really spend a lot of time in activities necessary to obtain that substance. Craving. So some people would say craving is present, but older adults also may not recognize substance cravings in the same way as general adult population is. And also with cognitive problems, there may be some confusion about physiological cues related to cravings. So people may just not know what they crave. And number five, recurrent alcohol use resulting in a failure to fulfill major role obligations, work, school, and home. So role responsibilities more common among older adults include caregiving for spouse with chronic illness, parenting of custodial grandchild, or for example, if retired older people with fewer familial or work obligations, substance use may not cause failure to fulfill major obligations at work, school, or home. It may still negatively impact, their health, daily activities, and functioning, but may not really result in failure to fulfill role obligations just because of the nature of role obligations. Number six, continued alcohol use despite having persistent or recurrent social or interpersonal problems caused by exacerbated by effects of alcohol. Again, if you rely on self-report by a patient, they may not realize their substance use is related to any social or interpersonal problems. And it may not be the case anyway, because a lot of times they engage in alcohol use while they are pursuing different social activities. Important social, occupational, or recreational activities are given up. Well, older adults may participate in fewer activities than younger adults. So it's difficult to know sometimes whether there is a reduction or not. And activities frequently continue and perpetuate drinking, right? People play golf and drink while we're doing that. That happens all the time. However, social isolation is related to substance use and should be noted and appropriately addressed. Number eight, recurrent alcohol use in situations in which it is physically hazardous. So older people, again, are much less likely to endorse that criteria of the using the hazardous situations. First of all, they may not understand that their use is harmful, and they may not identify certain situations as hazardous, or potentially dangerous. We're getting close. Number nine, alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problems that is likely to have been caused by or exacerbated by alcohol. Same issue. So people may not know what their physical problems, GI problems, so anxiety, depression, insomnia are related to alcohol use. And when we're going down to other physiological sort of neuroadaptation impact, you know, older people may have actually lower tolerance for substances like alcohol when younger. And they may experience harmful effects at much lower amounts of consumption than younger people. So they may have actually lower tolerance, and that criteria does not work as well, quite well. And withdrawal, it's maybe less obvious and maybe more drawn out. And as a matter of fact, older adults may not develop, problems with physiological dependence to the same extent as younger people to have actual withdrawal if we started to use substance in an older age. So what's the conclusion to all that? What we're talking about here is that, some or all DSM-5 substance use disorder criteria may not apply for all individuals. And what it means is that, some of these people may need treatment even when we don't meet DSM-5 criteria for substance use disorder, even 2 of these 11 criteria. And this is ICD-11 sort of classification criteria for alcohol dependence, right? As you know, we rely for our in our education and training on DSM-5, but when it comes to billing and CPT codes, we use ICD-10 and soon 11 criteria. So it's still called alcohol dependence. So ICD is not using alcohol use disorder in international classification. And it identifies 3 central features as impaired control, impact on social functioning, and physiological features, right? It completely omits frequency, time spent, and amounts from criteria. And therefore, in my opinion, ICD is more inclusive as it applies to diagnosing alcohol use disorder in older people. So there is a picture here, and it means we have a question to follow. And I have a couple of questions here throughout our discussion, which we need to go through. So for an alcohol use disorder, your client must have at least 2 out of 11 symptoms listed on DSM-5. Which of these symptoms may not apply to older adults? And A, craving, B, continued use despite knowing of the various physiological and psychological problems, and exacerbated by alcohol. C, recurrent alcohol use resulting in fulfill major role applications. And D, using alcohol in situations which could be physically hazardous. So the answer is obviously all 4 of them, as you could guess correctly. So what are the issues? The demand for services to address substance misuse on older individuals is increasing and continue to be increasing, and we expect that. And therefore, all healthcare professionals, but not only healthcare professionals, but also family, friends, caregivers, specialty healthcare providers, case workers, social workers, and so forth, clergy, even, the direct care providers, all of them have to be educated about how to deal with substance use in older individuals because it's so different. It's important to notice that substance use and chronic health conditions have compound effects on older individuals, and we'll go over specifically over each of these effects. Physical health, right? So you know very well that alcohol impacts physical health, but also mental health and cognitive functioning. This impact is usually cumulative. And, while the patient may be drinking habitually and with no repercussions throughout their adult life, the first manifestations may be in their older age, when the person is the most vulnerable in terms of physical abilities, compounding other problems with health, coping skills, social support, and such. Basically, it's well known, but rarely fulfilled premise that investment in healthy lifestyle in younger age pays off in older age, and it's like non-monetary insurance policy, right? Which doesn't cost you anything, but really you get a reward later in your life. Some of the manifestations in physical health have to do with liver disease, cardiac disorders, GI problems, neurological disorders. So older adults also more likely to have injuries, falls, and die in motor vehicle accidents if they drink. And chronic pain, we're talking about bidirectional sort of relationship here, may lead to increase in alcohol use. Some cancers reported to be more frequent with alcohol use disorders. And we, of course, know about interactions between alcohol and medications, which people taken for other medical problems. When it comes to mental health, all relationships, are bidirectional. And more often than not, they perpetuate each other. So that causes a lot of headache for providers when choosing treatment, whether it is medication or therapy, treatment for depression, treatment for anxiety. And, we ask ourselves, should I prescribe antidepressant medication for anxiety while patient is still drinking, right? Should I be seeing a patient in therapy session if I notice smell of alcohol in their breath, right? And on the first side, the answer is pretty obvious. And if you do what I think you do, you may lose a patient altogether from your practice. So when my students ask for my opinion, I usually respond with the same response. When I don't have a clear answer, I usually say no hard rules or absolute restrictions are allowed in our field, and it's all on case-by-case basis, right? And that's how I would say it here. Or in other words, since we mentioned artificial intelligence, the moment we start practicing in algorithms, the moment we stop seeing individual behind the diagnosis, that will be the moment when artificial intelligence will take our jobs. But certainly more frequent depression, suicidal behavior, anxiety disorders, and other problems related to alcohol use in older people, including increased length of stay in mental health hospitals. And I cannot not mention that there is significant interactions between alcohol and also psychotropic medications, medications for anxiety, but not only, and also some other substances. Now, cognitive impairment. Light or moderate alcohol consumption usually does not lead to any problems with cognitive functioning. It's not protective. There are some studies which may indicate that it is, but overall consensus, it's not protective of cognitive impairment. However, heavy alcohol use in mid to late life is associated with cognitive decline, right? And increasing the risk of developing primary dementia. and brain damage. On the other hand, people with primary dementia, Alzheimer, dementia, Parkinson disease-related dementia, or some others, they may actually develop alcohol use disorder for the first time, just simply because they're lacking that good understanding or judgment or recall how much they consumed. And of course, it is associated with increased risk of admissions, falls, head injuries, behavioral problems. So there is another picture of this man wondering if he should have another drink. And we come into the question. And the question is, who is at risk? So it's a busy slide, but basically, we want to talk about what's moderate drinking, what's high-risk drinking, what's heavy drinking, and binge drinking. So moderate drinking, it's up to 1 drink a day for women and 2 drinks a day for men. And exceeding this leads to high-risk drinking. That's the general sort of consensus. But for older adults, sometimes having even 1 drink, drinking at all, we could qualify as a high-risk drinking, especially in situations when we're taking prescription medications, when we have certain medical conditions like diabetes, heart disease, when we're about to drive a car, when we're recovering from alcohol use disorder and some other problems. This picture you've seen so many times, I don't need to go over it, but it's just a reminder of what 1 drink really means. And it's usually much less what people think it is. What's heavy drinking? So heavy drinking is 5 or more drinks for men, or 4 or more drinks for women. And we'll talk more about it later, why it's different. And it's in 1 period of each of 5 or more days in the past 30 days, right? Now, binge drinking we qualify as reaching levels of 0.08 grams per deciliter or greater of alcohol concentration. And it's usually achieved after 4 or more drinks. Now, all those criteria have to be modified for older adults because they're more sensitive to the effects of alcohol. And these numbers need to be lowered when screening for alcohol misuse. Because, we need much smaller doses, smaller amounts. We have decreased gastric alcohol dehydrogenase enzyme. The body composition is changed, decreased muscle tissue, declined lean mass, and also our organs kind of slowing down and slowing their functioning as we age, including kidneys, liver, and so forth. So the same criteria of 1 drink metabolized per hour may not apply to older people. And talking about difference between women and men, why is it so? Well, if you take men and women of about the same size and age, the woman will get drunk sooner because women have less body water, less lean muscle mass, and less of the enzyme which breaks down the alcohol. Therefore, older women who misuse alcohol over time are likely to have more alcohol-related health problems when older men do. And these problems may appear sooner and be more severe. And also important to know that, women are more likely to live alone longer, increasing their risk of developing alcohol use disorder. And they may be less financially secure and it's additional risk for developing drinking problem. And they are more likely to take benzodiazepine, which interacts in a harmful way. On the other hand, some research suggests that older women respond to alcohol treatment better when older men do. So what are the risk factors? Some of those are surprising and some are not, but this was confirmed twice, first by Medicare beneficiary survey and then later by National Survey on Drug Use and Health. So risk factors associated with unhealthy drinking are high education and income, better health status, right? So maybe, I guess, giving yourself permission to drink, male sex, younger age, smoking, being Caucasian, and being divorced, separated, or single. Again, some of it when I read, I didn't expect to find, but it is. In reality, in actual life, what are the risk factors? What do I see here working in this community where really about 40% of my patients are 65 plus, and Sussex County in Delaware has become sort of a retirement mecca. People move here because of favorable tax situation and being closer to the beach, maybe a little bit more temperate climate. And so people move here from all over the place, New England, Virginia, DC, Carolinas, and all the other places. And we experience financial strain, change in standard of living. So those are the risk factors, right? Job loss, retirement, divorce, separation, housing changes, emptiness, decreased social network, bereavement, meaning of life, grief over losses, and being a victim of theft. What are we talking about here is really at some point around mid-60s or approximately. Most of the people reach a point in their life when they go through a lot of changes, right? And these changes continue to accumulate, snowball in following years. And that frequently leads to drinking. So let me give you an example of a typical patient I see. So retired from some top-notch, job which was highly visible with tremendous respect from co-workers, management, community, substantial pay and savings, maybe worked for government in DC, maybe worked for somewhere else, some university, sold a house in Long Island or Arlington and moved with a spouse to a new house on the beach. Children live in other states, we work there, have their families. The plan is to be active, travel, exercise, hold hands, and walk on the beach. What happens? Lost job, right? So left job, retired. Lost self-identity because many of us, it's a huge part of our self-identity is what we do. Lost all familiar streets and street signs, right? Lost access to social network, all the friends are left behind, neighbors, starting all over again. And now having existential questions. What am I? Was it worth it? What is the point? What is the meaning? What will be the meaning going forward? And a little bit later, got diagnosed with chronic illness, difficulty to find a new doctor in a new place. And when spouse diagnosed with dementia, maybe, and the person becomes a caretaker. One of children, for unclear reasons, stops communicating at all. By the way, I see it very frequently. I don't know why, but this is kind of a sign of our times. Every other older adult comes here and tells me that their son or daughter stopped completely communicating with them, and we don't understand why. The other child is too far to visit and help. And now 40 years marriage, you spend all the time together with your spouse and learn that you don't even like each other, right? And so beach, big house, empty house, big problems. And so now we're sitting on a deck, drinking wine, looking at the sunset and waiting to fall asleep. It's very sad, but it's very real, and that's what we see. And I think that's probably very common in every community, and especially in communities where I am now. So this is how it was supposed to be. The picture I took here My son is doing a lot of sailing these days, and this is how it turns out to be, right? And so the question is, binge drinking is a drinking pattern that leads to blood alcohol concentration levels of 0.08 gram per deciliter or greater. On average, this occurs after 5 or more drinks in men and 4 or more drinks for women. When considering binge drinking in older adults, all of these are true except binge drinking appears to be more of an issue for older men than older women. Low alcohol consumption levels may be considered binge drinking. Binge drinking is fairly uncommon in older adults, and binge drinking is related to a number of health and safety issues, including accidents, increasing chance of physical injury, higher death rates. And it's accept question. And if you guessed C, you are correct. It's not uncommon in older adults. It is important to understand health literacy of person, such as ability to assess, understand, and communicate about health-related information. Some older people with low health literacy may have trouble talking about their substance misuse with their providers. They may also not understand, for example, what amount of alcohol is considered to be harmful. Be aware of older adults' racial, ethnic, gender, LGBTQ diversity when addressing late life substance misuse, health disparities, and barriers to access care, right? And also important to know that older adults are not homogeneous group. As with any group, they may hold very diverse range of opinions and attitudes. For example, baby boomers, people who born between 1946 and 1964, you could speak directly as they grew up in time when substance use was more culturally acceptable, right? They may have more permissive attitudes towards drinking and drug use, and they're also more likely to be willing to seek and agree for, specialized treatment modalities, right? But for example, adults born, before or during World War II are more likely to have moralistic attitudes about drinking or drug use. Attitudes, for example, which were shaped by Prohibition era or temperance movement, and they may be deeply ashamed about alcohol misuse or drug use, and so they will not talk to you about it directly, and because they may attribute it to moral failure. So there is some difference on how you approach people and how do you talk to them. This is very basic principles, right? So recognize the importance of establishing a collaborative relationship. It's a primary mechanism for engaging clients in treatment so they could change their behavior. Use proven treatment approaches. So approaches that demonstrated effectiveness with older adults. They include brief advice, brief interventions, as-peered, motivational interviewing, supportive therapy, problem-solving therapy, different types of individual therapy, and CBT, of course. Create a culture of respect. So I will keep saying that non-confrontational, it's focused on building all the clients' sense of value and worth. You have to acknowledge their, own lived experience, their wisdom. You have to express confidence in their ability to participate in treatment and accomplish their recovery goals. And you do need to respect sort of a customary social conventions. There are some groups of adults in this group, such as avoiding, swearing, using slang. You should ask people how they would like to be, addressed and how they would like to be introduced to others. And how you ask questions matter because, it's helpful to find out if people already have a concern about drinking before you start poking around, right? Because they may come to you and already share that concern with you. Is it difficult to diagnose alcohol use disorder in older adults? So there are two ways, I guess, to separate groups. One of them proposed that there is an early onset and late onset, right? The early onset for people who started drinking, before age 50, they stayed in denial most of the time, and they over time developed, medical problems. They have poor emotional skills. They may have cognitive impairment, and this is a more common time. And when late onset, they started drinking later in life, and possibly in context of the problems that we talked about a little bit earlier, like all the psychosocial issues, and we were abstinent for a long period of time, or we were drinking at the low levels for a long period of time. And these patients may appear too healthy to raise concerns. So, but either type can be easily missed if you're not looking. Now, in Australia, we have a little bit different separation of groups, and I like it really. They divide groups of older adults as survivors, maintainers, and reactors. And survivors are those who started drinking in their 20s. They prematurely.
Oh, you're on it too?
Well,
Excuse me, can you turn off your microphone? Somebody has it on. They prematurely age as they don't use preventative services, and they require services in their 50s already.
No, I heard you.
terrific guy.
Oh my gosh, I think that was mine. My audio's off, right? Unmute my audio.
Steve, can I ask you to
Yeah.
mute your audio, please?
Start video.
Oh, Steve, hit mute right there. Wait. Hold on.
Thank you.
All right, thank you, Steve. And maintainers are people who have long-term drinking, but started to manifest problems and as they are aging, right? And so they maybe did not change the amounts of drinking, but because they, can't metabolize alcohol as well, or maybe developed some other medical problems, they started to not be able to tolerate alcohol. And when finally reactors are the people who in the previous classifications were described as late onset. So we started drinking in the context of psychosocial stressors of older age. And this is a picture of, I don't know, I think to me, he looks like a survivor, rather. So we talked a little bit about increased vulnerability of older adults, and we mentioned their problems with changes in metabolism, physiological changes, which makes them more sensitive. But it's important to mention what makes them particularly vulnerable is that a lot of physical symptoms and psychological, psychiatric problems, cognitive problems, can be a manifestation of other conditions and alcohol use disorder, and alcohol can be missed. So we could, presume what patient is suffering from depression or anxiety or something else, or maybe developing some early onset Alzheimer or something. And in the meantime, the person is actually suffering from alcohol-induced problems. So asking is important. What are the barriers for seeking treatment? So there is, of course, negative attitudes. Some families or providers don't feel comfortable addressing substance use because of negative views. Maybe they're afraid of making waves and asking about the issue. Denial of the problem. It comes from families and friends. there is that accepting attitude, if especially the problem is long-standing. Okay, so what he's been drinking, there's few things left to enjoy, continue, as long as nothing happens. And, that just happens in different settings, and sometimes in settings where people live or they have their hobbies or activities, where it's perceived as one last pleasure. Lack of knowledge, of course, is a big one, and we need to be responsible for education of families about and the patients about physiological changes what occurs to their loved ones, right? And misinformation about treatment. There's some opinion there in some places that treatment of older adults for alcohol use disorder is too late. It doesn't make sense. It's not going to be successful. It's not true. There is a lot of data and research showing positive outcomes for treatment of alcohol use disorder in older adults. So when we're talking about lack of awareness, I frequently ask my patients to keep a log, to keep an account of how many drinks they consume, so we could review it at each visit and have something to go by. Failing to screen a client in, for example, her 80s for substance use disorder because people of her age would not benefit from treatment, maybe ages, right? And some of the other problems, but I wanted to mention here limited mobility. Our patients have difficulty sometimes getting to treatment, not infrequently. They move and buy a house, or they move to some facility, and they have a car, and there's still two of them, and and one of them can drive still, and the time comes, and suddenly they can't leave their house. They can't get on a road to go for treatment. So that is often a problem for our healthcare providers here. You wouldn't believe sometimes the things I see. I have a patient who comes in their 70s, and the patient is blind on one eye and has a limited depth perception in another eye, and she tells me, Dr. Lev, when I drive, I don't know if the car is moving ahead, towards me or away from me. Or another patient who would be falling asleep on a red light because of sleep apnea and narcolepsy, each time. So if you drive to Sussex County, Delaware, please be careful, leave a lot of room and space between the cars, because you don't know who is driving, how you're driving here. But normal life changes, moving to assisted living, and all the sort of adults, long-term care facilities, can also precipitate sort of this accepting behavior to drinking, loss, and so forth. I think we talked enough about that. I'd like to make a point. For older adults are increasingly willing to seek services. However, they end up seeing primarily primary care providers because of stigma attached to treatment, right? There is a significant shortage of treatment providers and programs for older adults, partially because of Medicare coverage as well. So screening is recommended for pretty much everyone for risky or hazardous drinking, right? And you have to screen older adults at intake and screen them regularly. And especially when you're starting new medication or when you suspect that something is going on or some injuries or accidents happen. And, remember that some of the adults may not be comfortable using computers or tablets, and some of them may not be able to read or write, so you have to be able to assist with that. And when you review that screening result and discuss with patients, and keep conversation open with not judgmental attitude, and they will be more comfortable with sharing information. What screening tools we use? Well, one of them is SMAS-G. It's a first brief alcohol misuse screener developed for older adults. It's just a screener, that's what it is. If client marks 2 or more items with a yes response, it suggests potential alcohol misuse. It has, so it's developed for geriatric population, but the original screener, MAST-G, from which this was developed, the shortened version, it has sensitivity of 93.9%, which is quite remarkable, and specificity of 78%. So it's very, very good. And but it's not a diagnostic tool. None of the screeners are diagnostic tools, including PHQ-9s or any of those other screeners you use, or GEDs and so forth. You have to treat them as screeners. Your diagnosis is done by clinical evaluation, and this is just a tool, right, which points you in a direction. The second instrument, which has a good validity and strong reliability, is Audit-C. The Audit-C was developed so the audit itself was developed for heavy alcohol use, and it can reveal alcohol misuse in people 65 plus. It's primarily focusing, as you could see, on amounts, time, duration, and all of that data. So on those items of DSM-5 criteria, which are not listed in ICD-11, actually, right? But it's a very good tool. I mean, it's translated to a number of different languages, tested across different populations, and quite sensitive, and it will identify the risk of drinking for both men and women. And and if it points in a direction there is a problem, you need to, of course, continue evaluation with other questions. Now, and finally, SAMI. SAMI is a different tool. It's actually from Canada, and it's very good, I think, and it's well used and adopted in different settings. It's 5 items, but if you could see, it's actually a checklist of problems and actually open-ended questions even, and none of them are focused on time, amounts, and duration of use. They all talk about psychosocial functioning and use that approach to identify the problem, right? Which is kind of neat, and I think is a little bit less stigmatizing and wouldn't lead to people misleading in answering. So I like it quite a bit. It's have recently experienced problems with any of the following: sleep, drowsiness, and so forth. So going to some physical symptoms, and when loneliness, sadness, activities, worthlessness, anxiety, and when some open-ended questions need. So there is a picture, and the picture of an older woman who is enjoying one of these English beers. I think it's Guinness, maybe she's drinking. So the question, of course, is following: what is the correct statement in regard to screening for alcohol use disorder in older adults? Audit is a 10-item screening tool for heavy drinkers. SMAS-G is a short 10-item validated version of MAS-G, an amount, frequency, alcohol use it's focusing on. 2 or more responses, yes, indicate possible alcohol misuse. C, if you only use DSM-5 diagnostic criteria to diagnose alcohol use disorders, you may miss many older adults with alcohol-related problems which means they may not receive proper treatment. And when brief screening instruments are known for low sensitivity and high specificity. The D, of course, is incorrect, right? So they're quite sensitive and specific. And if you guessed it's C again, you would be correct. If you only use DSM-5 diagnostic criteria, you may miss many older adults with alcohol-related problems. All right, let's keep moving because we maybe have another 10-15 minutes, and I have to talk to you briefly about some other things. So you know all, I don't need to go into detail how you assess for alcohol use disorder. You need to ask history, when it started, how it progressed, development of any tolerance, impact on social activities, co-occurring conditions, what medications people taking, and all of the other things. It's important to know that a lot of adults, older adults who are drinking, also taking medications, 1.7% of adults ages 65 and older misuse their medications as well. So they don't take them as prescribed. Some of them just simply don't remember how to take them. So when we take medications and drink on top of it, it of course causes medical problems. It increases risk of falls, and benzodiazepines are particularly problematic, and we are particularly problematic in terms of balance and losing reaction time and frequency of falls. It's remarkable that a lot of people I see here take at least, 6-8 medications, and a lot of those I see up to 15 or more medications every day. This is a real issue. Now, what are the groups of the medications which have problematic interaction with alcohol? Pretty much all of them, all of those medications, which we prescribe to our patients, they all have difficult problematic interactions. 87.5% of adults in the United States take at least one prescription medication, and 40% of older adults take 5 or more prescription medications at the same time. So what is the best treatment strategy, right? There's a lot of choices here, and the simple answer is no single best treatment strategy. Each older adult has an individual history, unique needs, different treatment may be required. It may be impacted by the severity of the problem. And for people who screen positive for substance misuse and need specialized addiction treatment, many can change their use through less intensive approaches, like professional advice, personal advice, some education, brief structured intervention, and level of intensity should match the severity of misuse. So this table kind of shows how to match progressively the level of intervention to our concern. And the higher level of risk, the more intense the intervention, and I would say that annual screening and provide information about recommended drinking limits here for low risk drinking and moderate drinking. Again, moderate drinking and high risk drinking can be interchanged depending on what else is going on with the patient, as we pointed out earlier. you have to match person to their level of functioning, and addiction treatment programs have begun to see an increase in admissions among older adults. They do best, people do best in pre-treatment programs that are age appropriate, if we have age appropriate care providers and people who are knowledgeable about aging issues. And sometimes, in some studies it's shown that older adults have actually better outcomes than younger people. But you do need to make some changes in your program, right? You need to provide treatment in daytime, right? You need to make sure people have transportation. You have to make environment easy enough for all the adults to navigate, right? Lighting, accessibility. You have to accommodate for vision, hearing, cognitive impairment. So, you may need to adjust with slowing the program pace. And you may need to also focus on some age-specific topics in your groups, such as social isolation, grief, loss, trauma, and so forth. I'm not going to go over that for the lack of time, but it's screening, brief intervention, and referral for treatment as BERT is recommended for yearly screening for all adults and when major life changes occur, and work in addiction treatment facility. You're very familiar with all of that. How to conduct these sessions. Very briefly, so as we naturally age, our cognitive functioning declines, and so we need to make certain adjustments when we provide a group therapy or individual therapy, when we include people in the intensive outpatient program or partial hospitalization program. We need to adjust for poor attention, right? And so limit distractions, make discussions shorter, break tasks into smaller steps, monitor for fatigue, and maybe shorten the length of the sessions. And there is also an issue of low speed of information processing. So that happens in many different situations, right? It happens when we simply feel anxious, or we have self-doubts, or we feel uncertain, when we are, it makes us to second guess, to be self-conscious. It happens with depression, with ADHD, with schizophrenia, with other conditions, but it also happens with dementia, and it also happens with normal aging, right? As we age, cognitive function in general begins to decline, and it doesn't mean that the person doesn't understand information. So it's not a sign of low intelligence, it's just completing certain tasks may be a little bit more difficult, or it may take longer time for people because of slow processing time. And quite opposite, some people have a very fast processing speed, right? And they may recall and quickly react, but it doesn't mean that they're necessarily more intelligent also. So it has nothing to do with that. But how do you address that? You slow a delivery, right? You give plenty of time. You break information in small components and address one thing at a time, and expect that individual will require more time to benefit from interventions. And that will help. And then, of course, learning and memory also requires repetition, written summaries at the end of the session, sending reminders, right? Setting an agenda. So all those things will help for people with mild deficits. If deficits are severe, you frequently need to involve the family member. You need to probably avoid treatments which are reliant on new learning of cognitive skills. You may consider some drop-in groups, for example, some help to use timetables, weekly planners, reminders, appointments, and so forth. So you have to be flexible. Now, what's executive functioning? It's really has to do with being able to follow through with tasks, right? So you planning, right? It's inner workings of the brain, which has to do with prioritizing tasks and making decisions, right? And if it is an impairment, there is time blindness. You're not able to keep and plan, to keep in mind and plan for future events, right? You have difficulty stringing together different steps in the process and organizing materials and so forth. So so there is that issue which is common, which is common really in a lot of psychiatric conditions, again, including schizophrenia, bipolar disorder, some dementias, depression, ADHD. A lot of them manifest with executive functioning programs. So you do need to adjust how you make group changes in the group. You need to discuss steps, pre-plan, and develop behavioral strategies around that. Therapy modalities, well, I don't know if I have time for it, maybe a couple of minutes. So CBT is well established, scientifically supported. It helps, relapse prevention, which includes social skills training and coping skills training, that is helpful also. And you're very familiar with this as well. So problem solving therapy is a very simple approach, and it's also very helpful for all the adults. We could learn easily, including those who have mild cognitive problems can utilize problem solving approach. And 12-step facilitation, with a semi-structured sort of therapeutic approach that links people eventually to community-based 12 steps program are also proven to be extremely effective. We need to remember about caregivers. You need to involve them into, all your treatment efforts. You need to include them in the recovery process. You need to educate them. You need to discuss with them their own issues and the issue of burden, and that the patient may perceive themselves to be a burden to caregivers. And that's, by the way, a highest predictive for a suicide in older adults, feeling to be a burden, right? And when you need to encourage caregivers to, of course, engage in self-care and maintain their own emotional mental health, because the caregiver burnout is quite frequent and quite problematic, and we see it all the time. With detox in older adults, we have to pay particular attention to their nutritional status and physical problems. Detox always is in inpatient setting, especially for older. And for medications, of course, we will use lorazepam and oxazepam, Ativan and Xerox, which clearance is minimally affected by age, right? Pay attention to time and deficiency as well. And just in conclusion about a couple of medications. So disulfiram, as you know, it triggers an acute physical reaction to alcohol, including flushing, plus heartbeat, nausea, chest pain, dizziness, changes in blood pressure, can be quite dangerous. It's supposed to motivate people to stop drinking, avoid drinking altogether. It's an aversion therapy, right? But because the way how it may affect all the people, it is generally not recommended to be prescribed in this population, even though it's approved by FDA for use in alcohol use disorder. Plus, when with disulfiram, people need to stick to strict medication protocol, and so any cognitive impairment may be an issue when taking that medication. Naltrexone, we're very familiar, very helpful for treatment of alcohol use disorders, and opioid use disorders. Vivitrol, of course, is the injection form, and most recently it's been prescribed for weight loss, for all kinds of other, behavioral addictions, including binge eating, weight loss contract together with bupropion, and even cocaine use disorder. You have to remember a lot of people who are your patients in older age take painkillers. They are in pain. So if they are prescribed any painkillers, and I'm talking about particularly like opioid painkillers and maybe even tramadol, probably should not be taken naltrexone because they will have withdrawal. So we have to be careful. And it may be tolerable, so we still prescribe it, but there is not a lot of data that it's good for all the people. Acamprosate, so look, I mean, it's difficult to remember to take one medication a day. It's almost never possible to remember to take it twice a day. Acamprosate is 2 pills 3 times a day. I mean, I don't really see how my patients who are older able to comply with it. Plus, it's removed by kidneys, even though it's not metabolized by liver, which is a good thing. But a lot of my patients have declining kidney function, so it could be also a little bit of a problem. So final thoughts. Before you treat someone, ask him if he's willing to give up the things that made him sick. The phrase is attributed to Hippocrates. And some of your patients, of course, may travel back in the memories and fell into emotional sinkhole and never returned. And, they're not looking to be helped or saved. Yes, explain everything and instill hope, but don't raise expectations too high of what you can do as a provider. Actually, you might want to lower expectations a little bit. And why? Because you should let patient take charge and own their recovery. It's most powerful. Recovery is a much larger vacuum, problem for elderly. As we know, for addiction behavior to subside, there is always an open, empty time and space to fill. And older people have much more difficulty finding these activities and filling this space. We have difficult time making connections and relationships, especially after they separated from real life in a new place. There's a lot of opportunities there, but this is where a community role becomes so important. And we have all these senior community centers and the places and clubs and all of those things where people can meet other people and find some activities to do to fill that vacuum when they're not drinking, engaging harmful behavior. When you talk to people, don't try to scare them, right? Don't try to scare them. They really are not afraid of anything, all the people. We're not afraid of whatever you have to tell them. Honestly, most of my older patients, when they're talking to me about their fears, they are afraid of one thing. They're afraid of becoming frail so much either physically or the mind, so they have to rely on the help of others, or they may become a burden, or they may not even have anybody around them to help them. And so, use it as a leverage, talk to them about importance of, staying healthy and staying cognitively and physically healthy for the rest of their life. And I don't know why I like these 2 quotes here. This is one from a very good Israeli singer, Asaf Avidan. One day baby will be old. Oh, baby will be old, and think about the stories that we could have told. That refers to me probably to what some of the grief, what our patients experience in older age when we're thinking about what it could be and it wasn't meant to be, and that sometimes triggers depression and leads to drinking. And Jack Carr, highly recommend, good stuff. He writes very good books, and there is a phrase there. I've told you before, as fast as you are, even you can't outrun time. It has a nasty way of catching up with you, trust me, I know. to me, it reminds us that we are terrible at predicting future. And one thing we know for sure, though, is that most of us here sooner or later will reach old age, and that we have to take good care of ourselves well in advance to prepare for it. Well, that's all. I think I fit, even though I had to go fast and ramble sometimes, but I try to fit it all in a time allowed to me. And some of the resources here, I mean, there's so many papers written, but I would direct you to the tip 26 from SAMHSA has a very good chapter on alcohol use disorders. Highly recommend. Questions, if there's any, I'll be more than happy to answer if I can.
Dr. Lev, there were a number of people who were asking for slides. Are you comfortable forwarding them to me and I'll send them out to folks?
Sure.
Okay.
This is the beach of the town where I live now in Lewes, Delaware, which is right next to Rehoboth Beach. Nice place, especially in the winter when you could walk the whole few miles of the beach and not meeting a single person there. Come and visit. No questions?
Better be careful what you ask for. You might get visitors.
Well, let me know. You know how to find me.
We'll have to have a big gathering down there, Dr. Lev.
All right, we should.
Yeah.
All right, guys. Well, I really appreciate you paying attention, staying through this for all that time. And it's a pleasure again to see you all, and I wish you the best.
Thank you, Dr. Lev. Great to see you.
Bye-bye.